Hi everyone, we'll get started for this afternoon's workshop, which will be on promoting community engagement in implementation science. So to start us off, I would like to invite Dr. Nur Afiqah binti Muhammad Saleh, who is a lecturer at University Malaya in the Department of Social Preventative Medicine, and she does a lot of work with HIV and people who use drugs. And her current research activities incorporate community-based participatory research components. So I think she's the best person to speak to us about this today. So I'd like to invite her to the stage.
Assalamualaikum, good afternoon everyone. Welcome to track A. My name is Ika Muhammad Saleh and I'm a senior lecturer at the Department of Social Preventive Medicine, Faculty of Medicine, University Malaya, and I'm also a researcher at the Center of Excellence for Research in AIDS Trivia. And I've been trained in public health before and in interdisciplinary studies combining disciplines in both medicine and sociology. So today we are going to do a quick interactive workshop which I will promise will take place after two presentations, my presentation, and we'll be listening from Prof. Stan Vermon's in a bit. Okay, just a quick brief on what we are expecting for today's session is first I'm going to talk about community-based participatory research for hard-to-reach population, and then we are going to slash off the Q&A session due to time constraint, and we'll save that for later. And then next we'll hear from Professor Stan Vermont on promoting community engagement in implementation science resources from the NIH and HPTN. Again, we'll see the Q&A later. And then we'll have a quick group activity where you'll be given a task to read through the scenario that I'll be providing, and also discussing your group's questions that I will be sharing in a bit. And then we'll come back together in a large group discussion, and we'll do some conclusion ending with Q&As. So traditionally we would have these instructions at the end of the presentation, but I would like to have it here so that you can have a look at the questions that are expected from you, so that when we go through the presentations later you can take down some notes, and probably you can use your phones to capture some of the points that I'll be delivering, and also some of the Prof. Stan's points later on. So what I'm expecting everyone to do in a bit is that based on this scenario, in recent years there's been an increase in the number of amphetamine type stimulant or ATS use, and the use of ATS can give rise to risky sexual behaviors, and also the number of HIV and Hep C infections. You are a part of community advisory board that seeks to implement harm reduction for ATS use through safer smoking to prevent sharing. So in your group, I would expect people to discuss members of the community advisory board. Who should you involve, and how will each member contribute to the success of this implementation? What is your positionality statement? What are your plans to implement harm reduction for ATS use with regards to community-based participatory research principles? So these are the questions, and you can have a look at what the contents are later for you to take some notes down. Okay, so before I dive further into the presentation, I would like to share this photo. This is a photo that I took when I was out following a community healthcare worker into the field, into the ground, and this outreach worker was conducting HIV and Hep C tests in what we call the shooting gallery in Semenyih. So at that point, I was doing a research on how the COVID-19 pandemic had an impact on how people are doing, the well-being of people who use drugs in terms of the types of drugs they're using, their socio-economic well-being. So those are the things that we would like to gather when we do this research. But I would not, without having this partnership with the NGO, I would not be able to know where the shooting galleries are. I would not be able to find out where these hidden populations are. And I still remember being there. It was nice to have, despite the circumstances, we had a group of people who use drugs sitting together in an everyday environment, and we are there, and they are accepting of us as an outsider, and they have opened up to talk to us. So it's a really nice experience there. But without the outreach worker from this NGO that we've engaged with, it would be impossible for me to reach out to these populations, because these are what we call hidden populations, right? And there are reasons why they remain hidden, especially from the eyes of the authorities, especially from the eyes of the police. First, there is the issue of the criminalization of drug use in our local context, where our people who use drugs are first seen as criminal and second only as a human being. So we don't really recognize them as people with complex needs, including drug dependence. So this is a population that are very likely to go to prisons, to engage through the criminal justice system, and they don't want to end up in these places, hence why they remain hidden. And also there's also this moral model of drug use, what the society perceives of them as in having poor lifestyle choices, immoral behavior. And then there's also this internal and external stigma that have been attached to this hidden population. Mistrust of the healthcare system due to the history and previous experience with the healthcare system. And these are the people who are living on the margins of society. And there are also other examples of hard-to-reach population, and other examples including the LGBT group, homeless people, high-risk youths, who are not easy to find. And challenges with health research involving key populations, first in terms of sampling. So random samples are often insufficient to accumulate large enough samples of hard-to-reach groups, people who, especially they do not want to be identified. And there are difficulties with sampling, and we tend to get low numbers of people, and it tends to be time and cost inefficient as well for sampling socially disadvantaged groups. So one of the things that we can do is that, okay, I'll go through that later. I'm just going to go through the challenges. And second, participation. Again, there might be a history of mistrust in research, or even with researchers, fear of the authorities, fear of being publicly exposed, particularly if they are engaged in illegal behaviors that are being perceived as immoral in the society. And we have seen this especially in research involving African Americans and indigenous populations who have a history of mistrust, of being mistreated. In terms of data collection, there is a barrier with language, the lack of education, low literacy barriers that may prohibit the collection of certain types of data. And then the intervention, the reuptake, there are certain interventions that are not aligned with the perceived needs or priorities of these targeted groups. And to overcome these challenges, there is a need to create partnerships with local non-governmental organizations or NGOs that can help us as researchers to gain access to an otherwise hard-to-reach groups. So we are developing this reciprocal relationship in which we are sitting together with community members to create this co-sharing of knowledge and learning from one another. And there are certainly community-initiated research projects that seek academic partnerships and use the outcomes to directly influence policy and program delivery. So there are specific roles that NGOs can play. Just now we talked about how random sampling can be challenging, especially reach out to key populations. So the idea is to collaborate with community organizations with easy access to key populations. So an alternative to random sampling would be to do a non-probability sampling, including snowball, social network or respondent-driven sampling, targeted sampling, capture, recapture, adaptive sampling, and there's so many other more non-probability techniques that we can incorporate. And in leveraging these partnerships with NGOs, there is an opportunity to use convenience sampling as well. There are even cases where snowballing techniques through respondent-driven recruitment are done by having the first seat among committee members, so even the clients of the NGOs, to further then expand the network to their peers. So on the right-hand side of the slide are the example of the ways from the RDS study design. So we start with an initial convenience sample through seeds. We identify the type of seeds and type of respondents that we want, and then we incentivize respondents to recruit their peers to participate in studies. So what we are hoping to get is that through this engagement of local peer or these known committee members is that we will try to increase trust and respond rates and to promote and educate people about research, including cultural brokers. We engage with what we call the cultural brokers to liaise between participants and researcher. And what we develop through this partnership is this advisory board, or we call the committee advisory board, that is likely to be beneficial and increase perception that research is committee-driven and responsive. So this approach to research is especially important when we're working with marginalized populations. And what committee-based particular research in committee engagement aims to do is that we want to engage people beyond, engaging committee as study participants. It has to be more than just incorporating them as part of our research as study participants. And I am going to show you an example of how we work through this with an NGO in looking at a study that links people who get drugs to specific HIV services in a minute. So it's a collaborative approach to research in all aspects of the research process, right from designing the project, right from implementing the project, data collection, and even in some cases data analysis. And we've got some publications that include committee workers as part of the authorship because they contribute in terms of analyzing data before. And what they contribute is this unique strength and shared responsibilities to enhance understanding of a given phenomenon and the social and cultural dynamics of a certain community. So the partners integrate, when we develop this community advisory board, these partners, these different stakeholders, they incorporate the knowledge that are linked with action to improve the health and well-being of communities. So there are 10 key elements of CPR which are essential, and the first key element is to recognize community as a unit of identity. It's an integral part of our partnership in making sure that the research is taking place. It builds on the strengths and resources within the community. We do know that for a fact that these community would have their own strengths and they have their own resources in terms of manpower or materials that would help to facilitate the research. Facilitate collaborative, equitable partnership. And what does it mean by being equitable? I will explain in a minute. In all research phases. Promotes co-learning. So we come into the room, we relearn, and then we unlearn, and then we relearn again from these community members. Integrates and achieve a balance between research and action for the mutual benefit of all partners. Emphasize public health problems of local relevance. What is problematic? What is a burden in that particular setting? And we expand on that. Involve systems development through a cyclical and iterative process. Disseminate findings and knowledge gained to all partners. This is also important as we move along the CPR processes. And it doesn't stop there because it requires a long-term process and commitment to sustain the program that we have implemented together. So if we're talking about CPR in the continuum of community engagement in research, so how exactly does the CBPR approach in this whole idea of getting community to engage in research? It's really important based on this diagram to kind of identify the various levels of community engagement in research, and this nice diagram, it serves as a guideline for us researchers to see to what extent have we involved researchers in our community. Right from the left, you see that there is no community engagement, and as we move along, we're seeing increased level of engagement through community consultation, community-initiated projects, CBPR, and towards the far right, we're seeing that the community are driven. They are the ones who are leading on community-based projects or even research programs. They are the ones who come to us and say that they have funds and they would like to conduct this research together with us. So that's the very end of the spectrum. But within this spectrum, we need to understand that there are also equity indicators that look at power control, ownership, decision-making. Are we making our own decisions as researchers, or are we doing this decision-making, shared decision-making with our community members? Influence, resource sharing, and also mutual benefit. Again, so these contextual factors, we're looking at history, trust, relationship building, respect and transparency. It influences and affects the points of engagement listed on the continuum earlier, and it may affect the type of engagement and the overall results of the research as well. And if we're looking at the equity indicators, the ownership, these are critical discussions that we need to make with our committee members in terms of looking at ownership and decision-making process, which makes CBPR research distinct from other traditional research. And it holds the promise of encouraging research to be more open to engaging community in research as well. And if to give a clearer description on what these different stages mean, this diagram reflects perspectives and also experience of the community at the top of the diagram, and also researchers at the below for each stage. So these slides will be shared with all of you, so you'll have a chance to go through the different stages as we're comparing perspective and experience of the community and researchers. Now, specific key activities that can take place. Conduct needs assessment. So this is important at the very first stage of CPR. We need to know what is problematic in that particular setting. We want to articulate the importance of the problem. So you can get data not only for research, not only for preliminary work, but also you can look at federal, state, and local level data to kind of justify your problem statement. And these sources should be reputable sources. It can be, like I've mentioned, data sets led by scientists, peer-reviewed articles, and policy reports. So we can do the needs assessment ourselves by looking at data collection involving surveys and focus group discussions, and you've learned a lot during this workshop about NGTs. So you can incorporate rapid approaches to kind of help you identify what the needs are. What has been done before, and perhaps to explain what interventions and programs have been created and whether or not these interventions have worked or not worked. And then you'll have this cultural competence or humility. You want to identify ways to work with the community to kind of learn what their values are, what their culture and the traditions. So you want to know all that. Capacity building, you want to describe key partners that will work with you as researchers to solve the issue, and each of these stakeholders would have their own strengths and limitations as we go along, and those strengths that we want to tap into. Clarify researcher positionality. So this is the aspect that I would really like to focus on. So it's the disclosure of how an author's the racial, gender, class, or other self-identification experience would influence research method. So usually, typically, it's a short paragraph highlighting key themes that the researcher has considered. They integrate their own understanding, integrate their own aspects, own identities in when they are responding to stakeholders, they need to clarify these identities, because in a way, by clarifying these identities, they will be able to give answers to who am I in relation to this study, how do I fit in the whole research process. And what approach do I use in this research, and what influenced this approach that I have chosen, and what have I done to account for any of my influence in this research. So by doing this, it enhances the validity of the empirical data as well as theoretical contribution. So it should address any predetermined position that the researcher has as an outsider. For example, for myself, I would use this personal positionality statement when I engage with committee members. So I would say that I am a female Muslim researcher from Kuala Lumpur, Malaysia. Since I would briefly describe what my past experience is, so I would say since the last 1 decade, I have been involved in numerous studies of HIV and illicit drug use in both my home country, Malaysia, and in Vancouver, Canada, where I have been fortunate to complete my doctoral degree. So I would also say that in this local setting, the socio-cultural context in Malaysia has posed unique challenges to effectively address issues surrounding not only in terms of drug use, but also we do have different sexual orientation that we need to acknowledge as well, that often is exacerbated by the avoidance of these discussions on these topics. So it's very important to say that I do not identify myself as a person who used drugs, therefore do not have lived experience. So I would not have shared experience with you as a person who used drugs. And I would also state that I remain cognizant of my personal biases, because I've already identified myself as a female. If I'm working with men who have sex with men, I will need to acknowledge that I don't have shared experience and that I have different identities. But I hope to do well to continue engaging in meaningful conversations by acknowledging the principles of human rights protection and do no harm. And finally, I would say that my interest in this work is born out of a desire to rebuild structures of power in ways that make room for people on the margins, especially people who use drugs, to have equal access to opportunities. So these are kinds of statements that when you reveal to your study participants as committee members, they would feel empowered to share their own perceptions, because they do know that we don't know. They embrace the idea that they are there to support us by sharing their own experience. Okay, a quick presentation on this partnership with Persatuan Islam Murni Malaysia. The Semara study. So it's a study to engage Malaysian people who get drugs to comprehensive HIV key services. So in a nutshell, what this study aims to do is that it wants to optimize the role of local community-based organizations in linking people who get drugs to appropriate services through this patient navigation model. We do know that the strength of community-based organizations is that they have outreach workers who are experienced, who probably have the same experience, to help us to reach out to key populations. And we are hoping to, we hope to implement, to apply the implementation science framework to roll this study out. And if you've been in Jocelyn's session yesterday, I think you probably have a better sense of what the entire research is about. But the research impact that we're hoping to get is at least 6% of PUID and their family members are engaged to HIV services, encompassing health and psychosocial components to improve health outcomes and overall well-being of people who get drugs. So the key areas of Islam Murni's involvement, even before we submitted research grants, we already sit down and try to look at where should we do the research, which areas that we have not explored yet. So we went to suburban, we decided to go to suburban areas of Kelang, Selangor, to look at how we can incorporate this study. And from structuring the research flow, we've got questionnaires and we go back and forth about the questionnaires, looking at what other aspects of research that you would like to see is important that we might not have been capturing enough. So these are the things that we sit down with and discuss on with the NGO. And training of RAs who are doing the interviews, making sure that they're using the right language, the right lingo in communicating with our people who inject drugs. Implementation-wise, we've looked at shared resources, shared material, manpower, expertise, and different materials in terms of rapid tests. We also involved in shared decisions. And then there's this level of engagement where they went together with us in meetings with the JKN, with the health clinic in Pandamaran, and right to this research dissemination where they're also being provided a platform to engage with the committee members and share their study findings. So yeah, this is part of the research that we did for the study in Kelang. So challenges to CBPR include maintaining the boundaries between researcher and people who are being researched, academic and activists. This is something that I struggle sometimes wearing two different hats. One as an advocate, one as an academician, trying to make sure that I strike a balance between two different roles. And then there could be tensions between research benefit and potential harm, including obligation to produce benefits for community-identified issues. For instance, if the research participant coming in with problems including homelessness, not being able to get employment, these are things that we want to address immediately, but this is something that we need to acknowledge is beyond the scope of research. So we need to make sure that we strike a good balance between these. Just a quick acknowledgement on the team members. If you're seeing at the slide, you're seeing many different organizations that are involved in the entire research platform. The NGO, we've got community representatives, we've got people coming in from the Faculty for Education to provide psychosocial support for the family. And then we've got people from Academy Pengajian Islam, NYU, and people from KK Pandamaran as well. I'm saving Q&A for later. I am now going to pass this over to Prof. Stan Berman. Yeah? Thank you.
So Ika has done a masterful job articulating the community participatory research challenges. I feel like we're not going to get to our group exercise if I'm not going to rush a little bit. So I am going to rush a little bit. And this did not work out, so let's forget that slide. This is a toolbox that is available through the HIV Prevention Trials Network. And I just wanted to highlight some of the elements that are available to you. A community engagement program that is described, a manual of operations, which is way too detailed, but it does have several pages on how the network organizes community advisory boards, and those pages might be of interest to you. A cross-network community engagement reporting system in which we actually try to gather data about the extent to which community advisory boards are functioning, descriptions of community trainings and past community trainings. In the HPTN, community trainings are focused mostly on studies themselves. So a particular study has been co-developed with community input, and there are elements where we have to broaden the training from the elite subgroup of people who worked with us to a much broader cadre of people in the community. So that's what that training is about. It can be as short as 2 days, it can be as long as 5 days, depending on the complexity of the protocol. We also have done manuscript preparation for community individuals can actually lead their own manuscripts. This is not necessarily easy for them because they're not necessarily, raised in the culture where writing elegant term papers in their college, some of them haven't been to college. Now, most of the ones who end up in our writing courses have been to college, but they haven't typically been to graduate school, and they may not have extensive English language writing experience. This is a few pictures from something we did about 8 years ago now in Stellenbosch with folks from Southern African sites. These are two publications from that training, and I show them to you as bookends because the first one was published a few months after the training, just the next year. And the most recent one was just published a few weeks ago. And you have to have a tail to training like this. You can't simply do the training, let the community folks go off into the sunset and expect the paper to magically appear. You have to be available for them, nurturing, assisting, until the final product is produced. You can see the topic here, the topics, implementing community engagement for combination prevention, lessons learned. So this is a very qualitative study. The community leader is here, one of the senior scientists is here, so it's back, and they very much were capturing the lessons learned, both positive and negative, from community engagement in that first year. This one is also interesting, where this was somebody who was a community mobilizer. And she spearheaded the idea of evening and weekend sessions to do a much better job recruiting men, because they were appearing in very low numbers during the workday. And it may not sound like much, but the data that were acquired, that were accrued in the course of the study, were very amenable to analysis to see the extent to which this shift that was done while the trial was going on actually improved enrollment or not. And we were proud of her for sticking with this. There's a link to a language guide, and what I mean by language guide is not foreign language, I mean sensitive language. So what kinds of terms have been more popular among persons living with HIV compared to other terms? To use an old example, sex worker versus prostitute. But there are more recent examples where the stigmatized word has evolved, or phrase has evolved, to something less objectionable to the communities themselves. And some of these are a little bit controversial. Some people much prefer the term pregnant persons, because there will be an occasional trans man who could get pregnant. Others say that's ridiculous. 99.99% are women, so pregnant women is a reasonable, thing to use, and that is a very active debate at the present time. So a lot of that is within this document. And then there is an Uber organization that coordinates many of the big NIH networks in HIV and has its own materials which can be accessed at their own website. So this is the vaccine trials, the AIDS clinical trials group, the impact group, and the former microbicides trial network, etc. There are community research resources that include research literacy. So how do you actually educate communities about what a clinical trial is, what implementation science might be, what an observational study might be, what a case control study might be, what a before-after strategy would be. Whatever it is, there are resources available that have been written for you to actually help you do this kind of work, this kind of community education. You don't have to reinvent the wheel. You can scour the internet, and if you don't find it in the NIH sites, you'll find it at CDC sites or the MRC sites. There are sites all over the world that are trying to share information to create research-literate communities. Ethics, research ethics. You might say that research ethics are in the purview of the investigators. We have to make sure the investigators are ethical. But you'd be surprised how well-meaning community members can do something that they think is the right thing, but is perceived to be unethical. For example, there can be cultures where people discuss their problems in sort of open sessions where violation of confidentiality can occur. Privacy can be disrespected, not intentionally. Nobody's doing this to humiliate someone, but it can happen. So even community organizations are not necessarily aware of every single ethical subtlety in biomedical research that some of us might take for granted. And there is this document that we've produced and we've revised in the HPTN that is a helpful guide to fundamental ethical principles, and that's downloadable and free and all the rest. Commentary about stigma and discrimination, and there again, if you have community advisory boards, they might be diverse. Is it conceivable that a bigoted person could end up on a community advisory board who has prejudice against a certain beleaguered subgroup? Sure it is. So one needs to consider stigma and discrimination training even for community board members. We have information about community engagement and how to forge community engagement, male involvement. So many studies are women and sometimes children focused, and the notion of how to appropriately engage men. Even studies that focus on men may need this kind of training on how to reach men, because as I alluded in the example of the manuscript that was recently published, men may not be available 9 to 5. They may be out in the workplace, and you may not reach them if you're not going out of hours. Sorry if I'm going a little fast here, but we very much need to get to the exercise. Okay, so now I'm going to go through some of the resources that are on this website. clinicaltrials.gov for registration. Be the Generation HIV Prevention Research Training Module, which is a little bit US-centric, but you can adapt it for Malaysian or Filipino or Thai or Indonesian needs. The Basic Scientific Literacy Training Module. So this is for folks who may not know what an antibody is, or may not know how an HIV test works, or may not know the difference between a bacterium and a virus, which, by the way, includes more than half the population of the United States. So the Basic Scientific Literacy Training Module is sometimes an illuminating opportunity for people in the community to feel empowered in their role as community advisors for research, because they're actually being given the vocabulary and the knowledge base to spearhead their advice, bring their learned experience to the fore, but being more aware of what some of the elements of the research are all about. So it's a win-win for the researchers and for the community folks, because we're trying to learn about community mobilization, community engagement from the community. Well, they want to learn from us too, and that's what this scientific literacy training module is about. We have the research ethics training curriculum for community representatives. So something that's very tailored for community representatives, written by community representatives, by the way, and we found it very helpful because it's in lay language and it's in a way that people seem to appreciate. There's a tool for understanding and challenging HIV stigma, which can be used for community advisory board or other community training to assist in addressing that. There's also a Men as Partners program that was written a long time ago, but really has stood the test of time. It really reads well even today as a way of promoting constructive roles for men in community work. Now, I wanted to just throw out something from my own experience that is probably not as well represented on the HPTN website, and that is the concept of health literacy and numeracy. So, health literacy is kind of captured by saying, do you understand what your doctor or nurse is telling you? Do you have enough core knowledge about health-related matters that if a doctor or nurse speaks to you about your health or about your loved one's health or about your child's health, you have a sense of what they're talking about. And health literacy is often assumed by practitioners, but often not achieved by the patient or the client. And health numeracy is a slightly separate concept where people may not be good with numbers. They may not appreciate that one number is actually larger than a number, or one volume is actually larger than another volume. There can be considerable confusion about dosing, and we've even had where clients and patients have gotten things backwards. So they think, half of 10 is 20. Well, that would be double 10. But there can be profound confusion among some people in the community around basic numeracy. And we did a body of work in Mozambique, and this paper, Measuring Health Literacy Among Adults with HIV Infection in Mozambique, we helped validate an HIV literacy test for the country of Mozambique, which was a tool that we were able to use subsequently. And then this one, I was very impressed with this study. Health literacy predicts pediatric dosing accuracy. So if you were not very health literate, you were making mistakes in the volume of liquid antiretroviral you were giving your HIV-infected infant. And these mistakes were profound, so that a mother might overdose the infant and essentially be out of medicine 20 days into a 30-day month, so that the last 10 days of the month the baby wasn't getting anything. And at that point, the baby was off antiretrovirals, so that's a perfect way to generate antiviral resistance. Now, the mother could be guided, and for example, instead of the spoon approach, you could give a syringe, and you could do a little tape around the 5 milliliter spot. As a practicing pediatrician, I must have done this 1,000 times. We used to do this quite routinely because it's hard to do a teaspoon of something to it, but it's relatively easy. You just do it, show it, and fewer mistakes are made. So this was another, here's the relationship between literacy, numeracy, HIV knowledge, and health-seeking behavior. And we found that there was a very strong association between literacy, numeracy, and HIV knowledge vis-a-vis health-seeking behavior. Now that may seem obvious to you, right? But it wasn't obvious to us. We didn't anticipate such strong results. Here's one assessing spatial patterns of HIV knowledge in rural Mozambique using geographic information systems. The notion that we can use modern technology to better identify the hotspots of community need in terms of upgrading literacy and numeracy. Not all communities are equal. Some of them have, on balance, higher health numeracy and literacy than others do, and you can do this. And here's one, adapting adherence support workers intervention, engaging traditional healers as adherence partners. So in rural Mozambique, you have traditional healers, and they have been generally thought of as part of the problem, not part of the solution, because they don't operate based on scientific basis. They're more spiritual. And some of the practices are seen as very bizarre. And doctors and nurses tend to be very hostile to the traditional healers. But we've had some success educating traditional healers, helping them with health numeracy and health literacy, and recruiting them as partners to the allopathic medical approach, to the PEPFAR-supported HIV clinics. We've had some success using them as adherence counselors, encouraging patients to use the medicine, even if they're also getting somewhat strange treatments from the traditional healers themselves. So if you can't meet them, join them, kind of argument. And these are some of the other elements, again, mysteriously came in a new font. I promised yesterday that I would check the slides, and I didn't. You know, I was just blowing them, my fault. So this is the website of the government, of the NIH, health information, and this is a community engagement site. But if you just type community engagement, NIH clinical trials, you'll get right to the site, because that's what I did, and I got right to the site. And these are some of the things that they have under this educational resources, glossary of common terms for healthcare providers, for parents and children, etc. So that's a little bit of what I wanted to share with you, that there are resources in large national and international networks. HPKN is an international network, and there are resources at the NIH. I don't have time to show you the resources of the CDC or the National Health Service of the UK or some of the Australian sites, but there are quite a lot of sites. And there are also resources from developing country sites. The MRC in South Africa has resources, and others. So you don't have to necessarily start your community education efforts, your community engagement efforts from scratch. Someone may have written something quite suitable for you and created tools that are quite reasonable for you to use, and you should try to seek them out for your own crafting of community participatory research, your own crafting of community advisory boards, and your own efforts to improve the health literacy, numeracy, research literacy of communities that you were trying to engage. And all of that will help you do what Ika was highlighting in her talk, reaching the harder to reach populations in respectful and mutually beneficial ways. So thank you. Now we're off to the exercise.
Thank you, Professor. So I think now we can do the group activity that we're planning to do with all of you. Just a quick question. Do we have NGO representatives here? Yes. Yes? A lot of you? Hands? Okay. Jocelyn and Hanya, are you here? Can you be community representatives, like for NGOs? Yeah, so I'm hoping that you can disperse around the room, sit at tables where this is an opportunity to kind of engage with people from the Ministry of Health. I'm sure there are people from the MOH here as well, right? And no, they're all there, never mind. But if we can have one table, at least 4 to 5 people, and then we'll have the committee members to kind of disperse around the room and probably sit at one of those tables. Nishan, do you mind help move people around? This is going to be a quick discussion within your group, and then we'll come back again as a larger group to discuss things. we'll have until 3:15. Now is 3 p.m. So in your group, in 10 minutes, discuss the following points, and probably I can move around these tables and help you figure out these discussion points, and then we'll come together as a group. Thank you.